Welcome. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website at www.nahatica.org. After completing this webinar, please upload and complete the quiz if you are interested in receiving a certificate. You can find the quiz in the file pod throughout this presentation on our website, or you can email the Training Institute. After completing this webinar, please upload and complete the quiz if you are interested in receiving a certificate. You can find the quiz in the file pod throughout this presentation. You can email, mail, or fax the completed quiz. Contact information is on the quiz itself. If you are a member of Nahatica, the certificate for the webinar is free. If you are not a member, the fee is $15. If you have any trouble viewing the webinar, audio problems, or have any technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you'll see today to Nahatica Training Institute at nahatica.org.
Hi, this is Jim Wolfing, and I'm going to be spending the next hour with you exploring the connection between prevention and recovery. I first want to acknowledge that this presentation was developed with the help and assistance of Stephen Gumbley of Gumbley Consulting and Training in Pawtucket, Rhode Island. We'll talk a little bit more about Steve in a minute. Where are we headed in this hour? First, we're going to talk a little bit about the learning objectives for this webinar, a piece about beginning the conversation, which is how did we get to where we're at in terms of looking at the connection between prevention and recovery, a definition of terms, focusing on prevention, then focusing on recovery, then taking a look at possible areas of collaboration between the two. The objectives for this webinar: as a participant, you will be able to identify the intersections between prevention and recovery approaches. You'll be able to define common terms used in both prevention and recovery. You will be able to describe a more holistic approach to the continuum of care, and you'll be able to describe specific ways in which prevention and recovery practitioners can better support one another. Guiding our conversation. I'd like you just to take a moment or two to think about these questions as they relate to your experience. What is the current relationship between prevention and recovery? The so what question is, what is the impact of this relationship? Is it less than ideal? And the now what question, how can we improve this relationship? For my both personal and professional understanding of this topic, the current relationship from prevention and recovery is scant at best. I am, or have been, a certified prevention professional for some time. I first got my certification in prevention probably in the mid-1990s, and I've worked in prevention since before that, probably since 1979 or 1980. I'm a person in long-term recovery, which for me means that I haven't used a drink or a drug to change the way I think, feel, or behave since September the 8th, 1984, putting me in my 31st year of recovery. And that recovery has impacted my life in many, many ways, too many to go into here, but suffice it to say that it positively impacts my marriage, my children, my relationship with my family, my friends, the work that I do, etc. And in those relationships, when I work in the field of prevention, rarely if ever do prevention professionals, are they involved in recovery. I don't mean personally, although that's probably true, but in terms of their personal work, they rarely if ever do anything with recovery. And when I work with recovery support services, of which I do a lot, again, those folks I don't think know much about prevention, nor do they see themselves as preventionists. What's the impact of that relationship, or the fact that there is little to no relationship there? clearly, both disciplines would be able to do the work that they do most efficiently and help the folks that they're trying to help in a better way if there was a relationship between prevention and recovery, and we're going to be talking a lot about that. And how can we improve this relationship? We'll be talking more about that as well. So how do you explore these concepts? How do we move forward on this whole arena? And when I'm working with preventionists, I often ask these questions, and I'll just talk to you a little bit about some of the responses that I get. You can see if they would match yours. What are we preventing? Now, many folks in prevention would answer that question in terms of what they're hired to do. So they might say teenage pregnancy prevention, they might say HIV/AIDS prevention, they might say elder abuse prevention, they might say substance use disorder prevention, or that sort of thing. But when asked to explain that, they're not really preventing those things because they don't, have any idea that they're actually going to prevent all substance abuse. That's not what they're preventing. What they really do is working towards helping to create healthy individuals and healthy communities to lessen the risk that these folks get involved in the harmful behaviors that they're talking about. So their goal and focus isn't so much about ending. I mean, somebody who's working the prevention of problem gambling has no goal to end the gambling. Their goal really is, again, for folks to understand enough about the activity of gambling to avoid or lessen the problems that can be associated with it. So that's normally the goal and focus for preventionists. It's really about health and making healthy choices. The environments that it happens in numerous environments. That again usually depends on the program and how the program is designed and where the funding is coming from in terms of the environment, whether that's a school or workplace or community or any of that. And the models and frameworks that can be used are many. Although I will say that in my work and working with preventionists, many of them really don't know what model they're following. How about exploring these concepts in recovery? What are we recovering from? That's a very interesting question because when you talk to recovering folks, in the beginning they might talk about the actual drug they use, but as they get further along in recovery, they really are more likely to talk about recovering from dysfunctional behaviors, dysfunctional environments, that sort of thing. Understanding that the word dysfunction comes from a Greek root dys, which means pain. And so dysfunctional more accurately doesn't mean not functioning. It more accurately means functioning in pain. What is the goal and focus in recovery? Again, rarely is the goal and focus after the beginning about not using the substance. The goal and focus is usually about living a happy, contented, useful life without substances. It happens in all kinds of environments, and it can be numerous models. Some folks may be familiar with the Recovery Coach Academy or the whole idea of recovery coaching. And in recovery coaching, the model is that we support all pathways to recovery. So that could be anything from self-recovery to 12-step recovery to abstinence recovery to moderation recovery to medicated assisted recovery, any number of different recoveries. I want to take a look at the continuum of care and how it has evolved to the present one that we use, because that will impact how we look at the connections between prevention and recovery. In the 1970s, when I first got involved, we talked about prevention, intervention, and treatment. That was the continuum of care, and further as that developed into the 1980s, we added and talked about aftercare. So it was prevention, intervention, treatment, and aftercare. Aftercare was really about that early time, and once one left a formal treatment setting and often focus most significantly on relapse prevention. The continuum of care in the 1990s, I apologize if your slide has these words split up a little bit, took them off a continuous line, a linear line, and placed them more in a circle. So the continuum of care included, again, prevention, intervention, treatment, and aftercare, where we began to look at them more connected in a circle than on a linear line. And finally, continuum of care today, as you can see illustrated here, that there are the domains of prevention, intervention, treatment, and recovery, no longer called aftercare, now called recovery, and that they're in a Venn diagram where there is crossover between all of the disciplines, and in fact, in one point, all four disciplines are joined together. I want to take a look at a continuum of care model first introduced by the Institute of Medicine in 2009, which takes a look at health promotion to include promotion, prevention, treatment, and recovery. Prevention broken up into universal, selective, and indicated, of which we'll talk about a little bit more. Treatment, talking about case identification, standard treatments for known disorders, and compliance with long-term treatment goals, a reduction in relapse and recurrence, and then aftercare, part of recovery, in terms of any sort of rehabilitation issues that are included there. and that all under promoting health. And what we want to take a look at, and we'll take a look at throughout the time that we spend together here, is that in reality, a recovery then overlaps, and going back to the model we looked at it in the care with the Venn diagram, back into promotion. And we should probably get on the same page in terms of some definitions as we keep repeating both prevention and intervention. So prevention, using SAMHSA's strategic initiatives, promotes emotional health and wellness, prevents or delays the onset of and complications from substance use disorders and mental illness, and identifies and responds to emerging behavioral health issues. And so you see there's a bit of more of a holistic approach in that definition in terms of looking at both emotional health, looking at wellness, looking about preventing or delaying the onset of complications from substance use disorder and mental health issues, and identifying and responding to emergent behavioral health issues as they occur. Next is a definition coming from William Lofquist that's been around quite some time, since 1983, published in Discovering the Meaning of Prevention, a practical approach to positive change. And that is that prevention is a proactive process of creating conditions and fostering personal attributes that promotes the well-being of people. Pieces that I like to look at when we talk about that definition is that it is proactive rather than reactive, and that it is a process. And then it really talks about two pieces of the pie. One is creating conditions, which is an environmental approach, and the other is fostering attitudes that promote well-being. That tends to look at individuals as well as communities. Treatment involves specialty centers that provide various levels of care to individuals with substance use and mental health disorders. Specialty treatment may include psychotherapy, medication, case management, hospitalization, and/or support groups. So treatment in this definition would be working with individuals who have made or been assessed with some diagnostic criteria. Our first discussion question: what is prevention? We just covered this a few slides back. A, promotion of emotional health and wellness. B, prevents or delays onset and complications for substance use disorder and mental health. C, responds to emerging behavioral health issues. And D, proactive process of creating conditions and fostering personal attributes that promotes well-being. Or you could choose A and D, A, B, and C, or all of the above. These are the type of questions that you will be taking when you, if you take the quiz to get your CEUs, and the answer to this discussion question is G, all of the above. So let's talk about recovery. This is SAMHSA's working definition of recovery. SAMHSA being the Substance Abuse Mental Health Services Administration. I apologize if I use acronyms and don't explain them. Recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Key in that definition for me talks once again about a process of change. It talks about improving health and wellness, not delineating what that actually means. Living a self-directed life, which is clearly about having control over my recovery process and striving to reach my full potential. We want to talk about engagement because engagement is going to be one of those arenas where prevention and folks working in treatment can probably find an easier portal to enter and work together. Engagement talks about identifying and making contact with members of the target group in their natural environment. So that puts the onus on both prevention professionals and treatment professionals to meet their clients, if you talk about treatment, to meet your community members in their environment rather than just in your place. It talks about establishing rapport. It talks about enlisting commitment to behavioral change. Once again, that is true both in treatment, which we probably understand that clearer, as well as in prevention, where you're enlisting the commitment of folks in the community towards some sort of behavioral change in that community, and providing information about risk behaviors and strategies to eliminate or reduce risk. It's almost always in my mind about reducing risk. It's difficult to eliminate risk, but possible. And we'll find that providing information is a key component in both prevention and treatment strategies. You can see that this all comes out of the Outreach Competencies Minimum Standards for Conducting Street Outreach for Hard-to-Read Population, and it gives you the site that you could go read the whole piece if you had the opportunity. I'm going to dig a little deeper and focus on first prevention and then recovery. Prevention. Let's talk about how it's done. Are interventions that occur prior to the onset of a disorder and are intended to prevent or reduce risk for that disorder. And so lots of times you may hear prevention folks talk about their work as before symptomology. And in a sense, that's true, but as we will see later when we talk about indicated prevention and selective prevention, that a person may actually show some symptomology. What they haven't been yet is diagnosed with the disorder. And so universal prevention interventions are interventions that are geared for the entire community. So these are interventions that are not narrowed down to a particular group, but are really everything from awareness and intervention, educational interventions, that sort of thing, that is geared towards the entire community and all members of the community. Versus selective, in a selective prevention intervention is where you are now narrowing that intervention down to a particular high-risk group. And so when I would be working on a college campus, as an example, and you would do universal prevention, that's your strategies are geared towards everybody in the community. If you were doing selective, you might pick a group that you knew to be particularly high risk. And so further example would be prevention of problem gambling. So if I was going to do a selective group on a college campus, I might look at college athletes because they have shown to have higher risk to developing gambling problems than the general student population, and they have shown that they meet diagnostic criteria at a higher rate than those in the general population. And if I'm going to narrow that down in prevention, now we're still all talking about prevention, to an even smaller group, I would go to indicated. And that would be, in my example, student athletes who have not necessarily, won't necessarily meet diagnostic criteria, but they have shown an instance of problem gambling, or they have shown an inclination towards other diagnostic criteria for problem gambling. So we're still not dealing with somebody who meets diagnostic criteria and therefore would meet the criteria for needing treatment, but we are talking for folks who have some problematic issues regarding gambling. They would fall into that indicated piece. But still, not to confuse, that we're still talking all about prevention here. We're not talking about treating. And to do that, to think about that, preventionists look at both risk factors and protective factors. And a risk factor is a characteristic at the biological, psychological, family, community, or cultural level that precedes and is associated with a higher likelihood of problem outcomes. So, as an example, covering both biological, psychological, and family at least, we know that a risk factor for a child or an adolescent to develop a substance use disorder problem would be having a parent who is and does have a substance use disorder. And so that is a risk factor. It doesn't mean that the child is going to become addicted to alcohol and or other drugs. It just means that there is a higher likelihood of those problem outcomes. That's a risk factor. There are many. Versus a protective factor, which is a characteristic, again, at the individual, family, or community level that is associated with a lower likelihood of problem outcomes. An example of a protective factor, given the example that I already used, would be for that child to have in their life a positive, caring relationship with a healthy adult role model. Doesn't have to be their parent. Could be a teacher, could be a coach, could be a community member, could be a neighbor, could be an extended family relative. But that having that person in their life doesn't mean they will or will not become addicted to alcohol or other drugs. It means that it lowers the likelihood that they will have those problem outcomes. That's a protective factor. Now, when we look at protective factors and we look at risk factors, we often focus on individuals, but we need to remember that individuals don't do this alone, right? They live in context usually of a family. Well, they do live normally. However you might define family, I understand that changes. But they have family, they have community, and they have society at large. And so when we look at protective risk factors, we need to focus not just on the individual, but we need to focus on family, community, and society as well. Now let's take a peek at recovery. We've used this definition already, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. The 4 dimensions of recovery include health, home, purpose, and community. In health, we take a look at overcoming or managing one's disease or diseases, as well as living in a physically and emotionally healthy way. So that's part of recovery. It talks certainly about managing your illness, but it also talks about living in a physically and emotionally healthy way. Home. Home would be a stable and a safe place to live. So when those of us that work in recovery and recovery supports focus not just on what the person themselves, but we also take a look at their living situation. Purpose, defined as meaningful daily activities such as job, school, volunteerism, family caretaking, creative endeavors, and the independence, income, and resources to participate in society. That's very broad. But again, in looking at recovery support services, you often find them helping folks to prepare for jobs. Could be resume writing, could be interviewing skills, could it be any number of those things. Could be how to use the internet to search for a job. We take a look at school and education and what goals might be available to the person to include these in their wellness plan. How to volunteer, how to take care of family issues, all those sorts of things rolled up in purpose. And finally, the 4th dimension of recovery is community, which is the development of relationships and social networks that provide support, friendship, love, and hope. And so again, that community can be defined differently for different people. Oftentimes when we take a thinking about substance use disorder, we think of maybe a 12-step program. But there's lots of different, and that's truly one, and a strong one. But it could be any number of different social relationships and support groups that provide that support, friendship. Recovery is about wellness. It is contagious, and I'm going to get back to that in a minute. It differs from person to person. It almost always involves some sort of connectedness to others, and it requires choice. I need to be able to have control over what part of my wellness I'm working on and when. To get back to contagious for a second, I'm going to offer you something that comes from the work of William White, because people don't really understand this concept. So I'm going to quote him directly. Quote, "Recovery is contagious only through interpersonal connection, only in the context of community. The contagion of addiction is transmitted through a process of infection, the movement of addiction disease from one vulnerable person to another. But the contagion of recovery is spread quite differently, not through infection, but affection. Those who spread such affection are recovery carriers. Recovery carriers, because of the nature of their character and the quality of their recovery, are far more than the removal of drugs from an otherwise unchanged life. They tell us that we have the potential to get well and to get better than well. They challenge us to stop being everyone's problem and to become part of authenticity, respect, and moral equality, lacking even a whisper of contempt. More importantly, they offer us love." And I offer that piece from William White, again, to think about the connections between prevention and recovery. Because this piece in recovery begins to sound a lot to me like prevention, and a lot to me about community involvement and capacity building in the community. Understanding recovery, things to keep in mind. It differs from person to person. There are many pathways to recovery, and we need to support them all. And not only that, even within what you might think of as one pathway. So we might think of 12-step recovery as one pathway. But even in 12-step recovery, how a person uses that resource changes from person to person. So we need to keep the authenticity of the recovery process and the power to make those choices in the hands of the person in recovery. It's absent a sharp delineation of the severity of the problem. What's a problem for the severity of a problem for me may not be the same level of a severity of problem for you. There's sharp delineations. That's why when we work with people in recovery, they might choose widely different aspects of their recovery to work on because they view the severity of that issue differently from one person to another. This one is striking to most of us. It is resolved without treatment or mutual aid by 75% of those people in recovery. That doesn't mean they're doing it alone. It just means they did not have a formal treatment episode and they do not rely on mutual aid, such as 12-step recovery or rational recovery or women in sobriety or those types of mutual aid groups. 75%. That's out of research done by SAMHSA and others, and it means that the majority of people who are in recovery have done it using their natural resources and their natural community connections and not those. And those of us that work in the field, both in treatment and treatment recovery and even in prevention, we don't see them, so we don't know that they exist. And then finally, a thing to understand about recovery is that exposure to the most acute 10%, those in treatment programs, limits our understanding of recovery. And so those of us that work in the field, again, I think whether that's prevention, intervention, treatment, or recovery supports, are used to thinking about really the most acute folks. It's the most acute folks who access our treatment. So of course, those are the folks that we're most in tune to, but it changes our perception of what recovery is. And so we don't think of recovery about the folks that did not meet all the diagnostic criteria, just met some of the diagnostic criteria, and managed to turn their lives around without formal treatment. One arena where I think we can make sense of this and do take a look at this is many of us ourselves are or either know someone who was once addicted to nicotine who no longer smokes. Now, I don't have a figure to toss to you out of research, but clearly almost all of the folks that I know that were once smokers and have quit smoking have done it without formal treatment and have done it without going to Nicotine Anonymous or Smokers Anonymous. And yet that's a very powerful addiction. So when we remove it from drugs and alcohol, I think it's easier to see. And we just need to realize that those folks that are out there, there's a state in New England, Massachusetts, who now has 10 recovery centers, and at those recovery centers, they started asking folks who dropped in for support of the recovery process about their formal recovery, their formal treatment experience, and the majority of them had no formal treatment experience. And so these are folks that have never been on our programs, have never gone into a formal treatment, and yet are out there in the community in recovery and coming to the centers by word of mouth because of the support systems that they know exist. Getting closer, individual engagement. Because they target individuals, this is where we're going to begin to explore the prevention and the recovery connection. So because they target individuals, selective and indicated prevention interventions begin to connect with persons who may need recovery. Again, I'm not talking about how many of the diagnostic criteria they meet, but remember, in selective interventions, we're working with what we know to be high-risk populations. And so, going back to my example of college athletes, we know that they're high risk. So developing programs that meet all college athletes aren't identifying individuals that need treatment. That's not the purpose of the prevention. But there are people in that group, who are likely going to need treatment. And that's even more so when you move to the indicated populations. Because remember, the indicated populations are people who have shown that they have experience with problematic behaviors regarding the substance or behavior we're trying to work with. And so, again, Do they meet 5 out of 10 criteria? Would they meet your program's diagnostic criteria? We don't really know, and we don't need to know. What we do know is that when we're working in prevention and we're doing selective and indicated prevention interventions, it is likely that we're connecting with people who may need recovery. A person in early recovery is often faced with the need to abandon their friends. How many times have you heard that? And those of us that work, we do tell folks that. We tell them that they need to change their friends. They need to change who they hang with. They can't do their same social networks. that to abandon their friends or social networks that promote and help sustain a substance use disorder. So that makes a lot of sense. But often there's no alternatives to put in that place that support recovery. And that gets into both recovery supports, but it also gets into community development. And it's one of those areas where preventionists and treaters could find common ground to collaborate. So let's reimagine the continuum of care. The slide asks you to think about, based on what you have learned about recovery, and what changes might you make to this model, and what does the current model not reflect about recovery? Again, the current model shows recovery all the way off to the right on one side. It doesn't show any connection to prevention. And so a continuum of care reimagined might be all the spokes that you see there, but put in one circle so that they're connected. I want to talk a little bit about social capital equaling recovery capital, and to talk a little bit about what we mean by recovery capital and some examples of recovery capital. Recovery capital is the internal and external assets required to prevent problems and to initiate and sustain long-term recovery. There are different types. We're going to be talking about the different types of recovery capital in a minute. But I want to focus on two things here about recovery capital. One, it is indeed individual. It can be focused on, as a recovery person, my capacity, my internal and my connections to outside of myself that help initiate and sustain my long-term recovery. That's the individual focus. Recovery capital, though, can also take a look at the community's capacity to sustain long-term, initiate and sustain long-term recovery. And one of the ways a community could address initiating long-term recovery would be to work on the issue of stigma. Again, SAMHSA's data would show you, and this number changes from study to study, but somewhere between 10 and 20% of all folks addicted to either alcohol or substances in the United States never once seek help of any sort. And the issue there, the main reason folks don't seek help, is stigma. The shame that's involved in acknowledging one has this illness. Even thinking of it as an illness, as a disease, rather than as a personal failing. And so one of the ways that a community could work to build social capital and have that building of social capital equal recovery capital would be to anything that one could do to help reduce the stigma of having that disease in the community. There are other examples that have gone. One example that's taken hold in a number of different states or municipalities as well is the whole Ban the Box initiative. And so Ban the Box initiative, if you have not heard of it, is about not asking on an initial application for a job whether the person has been convicted of a felony. Now clearly down the line that information is going to become known. Clearly hiring institutions might want to do a background check. No one's saying that that needs to remain hidden. What it is saying is that it denies recovery capital by having it on the initial application, because those applications rarely get a second look, and the person never gets to come in and tell you that that was 20 years ago, and they've been in recovery all that time, and now that they're a protective member, they never get that opportunity. And so again, another way that a community could move towards building social capital that would be recovery capital would be to look at the blocks and obstacles that exist in the community for individuals to sustain long-term recovery, initiate and sustain long-term recovery, and do what they can to eliminate some of those blocks. We talk about recovery capital, personal, family, social, and community. I've really been given kind of examples about that. Our goal is to build recovery capital at all levels, to build it in the individual, to build it in the family social setting, and to build it in the community. We must assess recovery capital on an ongoing basis. This isn't a one-time deal, it's an ongoing basis. Our work is to support recovery-linked cultural revitalizations and community development movements. We need to constantly evaluate the effectiveness of both our prevention and recovery programs and your own personal response to the recovery community. Recovery capital is the breadth and depth of internal and external resources that can be drawn upon to initiate and sustain recovery from severe alcohol or other drug problems. That comes from Cloud and Branfield in 2004. Recovery capital is conceptually linked to natural recovery, solution-focused therapy, strengths-based case management, recovery management, resiliency and protective factors, and the ideals of hardiness, wellness, and global health. And so I hope we're seeing that this whole arena of recovery capital is a place that both preventionists who are working on community development and community wellness, and treatment folks who are working with individuals, as well as the whole move towards recovery support services, which we're going to talk about in a minute, can work together. So what is the prevention and recovery dynamic? Recovery being in the middle, risk factors and vulnerabilities, clearly things that both preventionists and folks in treatment work with and talk about and help folks to understand, and then recovery capital and protective factors. And so again, the language is different in our domains, but the work is really very similar. And so in prevention, we're talking about protective factors and risk factors. In treatment, we're probably talking about vulnerabilities, and in treatment and in recovery supports, we're talking about recovery capital. And in recovery, those domains can all meet. So what do prevention and recovery have in common? You see a Venn diagram here that takes a look at prevention and recovery, with prevention on the left circle and recovery on the right circle. They both have a goal of wellness. They both have increasing protective factors and reducing risk factors. They both look at community involvement, and they both offer hope for the individual and the community. And so in this movement towards closing the IOM definition from a protractor to a circle, these are areas that we can take a peek at in terms of working together. So lots of areas in there that we could possibly work together. And even so strategies for health promotion include prevention, include engagement, and include recovery. And so plenty of places to think about working together. When we take a look at health promotion approaches, in prevention, we focus on the person at risk, but we also focus on strategies focused on the environment, focusing on the public at large, focusing on high-risk individuals, and in engagement, we have outreach and community engagement. And when you take a look at the right circle, we have recovery. Recovery looks at pre-recovery supports, the transdisciplinary interventions, specialty treatment, mutual aid, recovery support services, recovery supportive communities, and community engagement. They also look at strategies focused on the environment, focus on public at large, focusing on high-risk individuals, and have it as outreach and engagement as a commonality. Another way of taking a look at, another way of thinking about how prevention and recovery are often doing similar things, they're just not doing them together. They even share similar populations, but they're not working together. So connecting prevention and individuals in recovery, connecting prevention and the recovery movement, recovery support services, recovery community organizations. We're going to look at all of these in a minute. Our second discussion question: what do prevention and recovery have in common? Community involvement, we know that that's true. Hope, we know that that's true. The goal of wellness, we know that that's true. And increasing protective factors and decreasing risk factors, we know that that's true. So the answer to our discussion question would be F, all of the above. Where substance use and problems are active in the community, we have prevention using universal, selective, and indicated. We have recovery support services. We have outreach, all happening in the community, all addressing the issues of maintaining wellness for the family, the community, and the individual. So to talk a minute about recovery community organizations. Now, here in New England, all 6 New England states have recovery community organizations, statewide recovery community organizations, as well as, in some cases, local community recovery organizations. Now, I say that it's in New England, but outside of New England, this is going on in many, many places throughout our country. So what is it? A recovery community organization, an RCO, is an independent nonprofit organization led and governed by representatives of local communities of recovery. Now, in some cases, those are all people that are in their own recovery, and in some places, that's identified as people in recovery, family members in recovery, and allies in recovery. But the piece here is that it's independent and it's governed by those parties, not by an outsider. The sole mission of a recovery community organization is to mobilize resources within and outside of the recovery community, so both within the recovery community at large as well as outside the recovery community, to increase the prevalence and quality of long-term recovery from alcohol and other drug addiction. And so that's their sole mission is to take a look at that resources exist in recovery community, resources that exist in the larger community that support long-term recovery. They organize recovery-focused policy advocacy and activities, so that advocacy is an important piece of what recovery community organizations do. They carry out recovery-focused community education and outreach programs. So and they also provide a lot of peer-to-peer recovery support services, things like recovery coaching, telephone recovery support, and others. So recovery community organization core strategies, public education and awareness. There's so many examples, and so lots of times those are training sessions. Those are training sessions that are developed particularly with the recovery community involved. They might be public education and awareness around stigma and those sorts of efforts. Policy advocacy. So the Ban the Box policy initiative would be a policy advocacy. Moving away from just criminalization of addiction to treatment of addiction would be a policy advocacy. And there are many possibilities there. And then peer-based and other recovery support services. So that's a core strategy. I mean, that's probably the one that we think about and focus on the most. But in reality, education and policy advocacy are strong components as well. But we think about peer based recovery support services, when we think about recovery coaching, when we think about telephone recovery support and other services. And so this is the one-on-one sort of peer outreach and peer connection to help a person identify the obstacles that they might be experiencing in their own recovery journey, and then to work with planning a wellness plan that would help these folks overcome or minimize, if possible, these problems. So what do RCOs then and prevention have in common? They would have in common leadership development. Prevention definitely works on leadership development. When I'm a prevention professional and I'm going into a community, I'm always, one of the things I like to think about being a preventionist, that my job is to always work to be out of a job. And so that working with a community, prevention works best when we're following a capacity building model. Could be a public health model as well that builds on building capacity. But basically, you're always working on establishing in a community the leadership and the volunteers that community no longer needs you to continue their prevention effort. RCOs in prevention have community strengths and needs assessments, so data collection. We're getting much, much better at this in all these disciplines in terms of doing needs assessment, doing, in prevention we call it community readiness. In recovery supports we talk about building community recovery capital. But in both instances, we need to do some needs assessment. We could do some focus groups. We could do, if we didn't have the money to do a formalized needs assessment, we could do key informant interviews. There are a number of different ways that we can do that data collection. RCOs in prevention have public education and awareness in common. Public awareness and education is a key component of prevention strategies. It's also a key component in recovery community organizations. And the thing that amazes me working in both of these disciplines is how often the message is the same. And so imagine the collaborative possibilities that exist there when doing public education and awareness. And finally, policy advocacy. In both instances, folks, we're talking about wellness. We're talking about community wellness. We're talking about individual wellness. And so many of the policy initiatives would be effective for both. I'm not saying they're all going to be the same. I'm just saying that it's not difficult to imagine a place where preventionists could walk into their statewide RCO and say, can we just have a meeting and talk about areas of potential collaboration, because I think we might be doing some of the same things and reaching the same populations. And conversely, those of us that work in recovery supports and work for recovery community organizations should be asking preventionists to be on our boards, should be asking preventionists to come to the table, should be asking preventionists if they want to do some volunteer work. I mean, and yet oftentimes I think that this does not happen. In fact, I'm not saying I know everything that goes on everywhere, but I find it rarely to be happening. So in this hour, we have examined many possibilities and many areas of common goals, tasks, and potential areas for collaboration. I hope that we continue this conversation and that we find the way to get out of our domains and to reach across the continuum of care and address wellness in all of our work. And I thank you for being with us.